this video, I'm going to try and answer some of the many questions I've received about back pain and surgery for back pain. I recently posted a video here on YouTube with a provocative title, Why Surgery for Back Pain Doesn't Work, advice from a spine surgeon. And this has generated a lot of discussion, quite a few questions and comments, and also a lot of subscriptions to the channel, which I'm very grateful for. I'm Anthony Gosh, I'm the lead neurosurgeon of the Spine MDT. Please subscribe to the channel. It's not monetized in any way. The more subscribers there are, the easier it is for patients or people suffering with back pain and spine disease to find useful information on this channel that we try and post weekly. So the absolute first thing I want to clarify is that these videos do not constitute a consultation. We're not forming a doctor-patient relationship. If you've been given advice by a healthcare professional, a surgeon who has physically seen you and examined you, gone over your scans and formulated a plan with you, that is far superior to anything I can present or any advice I can give you on this channel. The biggest take-home point I wanted to make in that last video on why surgery for back pain doesn't work is that for the majority of patients, the common causes of back pain that we see, surgery isn't the answer and rarely helps. But there's a minority of very specific conditions where it can help. And therefore going through the right process of an assessment with a good healthcare professional that specialises in spine disease in some way, be it an osteopath, a chiropractor, a physiotherapist or a spine surgeon or a pain specialist, but particularly if they work together, then what should happen, or what the Spine MDT tries to do in this practice, is filter through those patients that will benefit so that they land in front of a spine surgeon who can go through it with them. But for the majority of patients, it doesn't work. But what I'll try and do is answer your questions one by one. Someone called Stephen Williams asked me about the Duke laser disc repair. So I'll try and answer that by explaining what a microdiscectomy is itself, that the open surgery for a disc, versus laser discectomy, and then the Duke laser repair method. So if you have a herniated disc shown here, this is a cross section across your waist, a bit of herniated disc poking out, pinching the nerve. One of the methods to treat it is a microdiscectomy. It's surgery through a minimally invasive technique where, if we come down, this is off my blog, there's a link down below to this. You make a small incision for a very narrow channel. You make a tiny window in the back of the spine, and under the microscope remove that herniated fragment to alleviate the pain. So laser surgery itself is when you pass a kind of tubing or a needle down into the disc itself, and the idea is it burns. Using the laser, you kind of burn a hole in the disc, which is a vacuum, which creates a vacuum, and then that vacuum sucks back this bit of disc herniation. Now, the trouble with that is that can work if you have a very soft, acute, loose fragment of disc, rather than one that's formed over time and then has become hardened on the outside. Sometimes you can judge that on the scan, on the MRI scan from the history, but it's not always easy and not that accurate. And in my experience of patients who had it, the results are mixed. It's all about patient selection. Some patients have done okay with it, but some haven't really noticed a difference and have needed the traditional surgery anyway. If the disc is that loose and protruded, there's an even less invasive way of doing it. There's some manipulations that a good physiotherapist, chiropractor, or osteopath can do that I work with, that puts a little bit of traction on the spine. So imagine if you were to grab this bone and gradually pull them apart, you create that same vacuum effect and suck the disc in. So I'd certainly try that method first. And if it fails, you can also try an injection. It takes away some of the inflammation until your body heals up the disc. And then if that doesn't work, then surgery to shave off the disc. I personally don't believe in the laser surgery. Now, the Duke method, from what I've read, uses an endoscope to take the laser beam down to the disc itself. So that means instead of surgery where you when you do the operation, you come down the middle and you make a tiny little window under the microscope in the bone, whereas their method is you come in from the side, you come at a bit more of an angle, and attack the disc from this way with an endoscope and then the laser. Well, my argument to that is, if you're getting an endoscope down there where you can see the disc, why do you need the laser? Why not just shave away that bit of disc? It's just as minimally invasive. So that's my my answer to that. There's a lot of marketing around a lot of the newer techniques in spinal surgery about the bony disruption, how if you create a window of bone, if you remove bone from the spine, you will end up needing fusion someday in the future. That's complete nonsense. It depends how much bone you take away and how much of this area of bone here you disrupt. So on the side view, it's this bit here, the facet joint. If you remove a lot of it, then yes, it can destabilize the spine. But for a minimally invasive microdiscectomy, where you just create a tiny little window just next to that joint, the amount of destabilization is minimal, is nothing. And provided you maintain a strong core and do the right exercises afterwards, you should be able to prevent that completely. And regardless of what procedure you have, I always advise patients to maintain a strong core anyway. That's the overall long-term treatment of treating this disease. So I'm not completely against it, but you've got to be very careful in the patient selection as a surgeon, who's going to benefit from it and who isn't. And that's not always easy to get right. The traditional methods of treating it for a microdiscectomy is a very today anyway, the way we practice it with microscopes, a very minimally invasive procedure, fairly quick recovery, and it's quite definitive. The newer methods of laser where they use an endoscope, well, if you can physically see the disc with the endoscope, why stick a laser needle in it? Why not definitively shave it away? I mean, the invasiveness to get there is exactly the same. So it just, to me, just for me personally, that procedure doesn't make sense. Someone called Joe Langford asked, we assume that I only do surgery for leg pain, and even then it's still selective. And then there's also some stuff about scoliosis and lots of videos online with success stories. Well, look, of course there are lots of videos of success stories, and it's good to celebrate successes, but I think it's equally important to recognise complications as well, and that's something we don't often publicise. It depends on the cause of the problem and the underlying findings on the scan. So, to clarify that, if you have a slipped disc pinching a nerve, as previously illustrated in the last case, causing leg pain, then yes, the evidence suggests that removing or shaving away that bit of disc primarily alleviates the leg pain. So when I'm obtaining informed consent from a patient, if I'm obtaining their consent, that's all I can truthfully say. It's likely to alleviate your leg pain. However, a recent study showed that in those same patients, you can actually expect some reduction of your back pain. There was a study that demonstrated that. However, we mustn't misinterpret that and believe that we're doing it for back pain. So, for example, if you have back pain and a scan happens to demonstrate a slipped disc pinching a nerve, but you don't happen to have leg pain, and you see that from time to time, you cannot promise a patient that you can alleviate their back pain by shaving away that bit of disc, because that's not the primary purpose of that operation. So I hope that bit makes sense. Scoliosis is a completely separate kettle of fish. It's scoliosis, firstly, for those of you who don't know, it's a sideways curvature of the spine. Broadly speaking, there are two main categories. You've got adolescent scoliosis, where it happens presumed as a problem with the growth plate and therefore uneven growth, and it tends to start getting exaggerated in that post-pubertal period where you have a growth spurt. It depends on what we call the Cobb angle, the maximum angulation of that curve, and how much debilitation that causes patients, nerve entrapment, severe pain, severe deformity. Then yes, there are success stories with scoliosis. I've seen them myself, and I believe in that. There are very good teams of people. That kind of condition is managed by a multidisciplinary team of orthopedic spine surgeons, primarily pediatricians, physiotherapists, and a whole group of people where the decision is made. And so, yes, I've got nothing against that. Then you've got the adult degenerative scoliosis, where you start to get wear and tear in your facet joints, through bad posture, and the same reasons we all get wear and tear. The spine becomes a bit crooked at the bottom, usually in the lumbar region. And then there are scenarios where surgery is beneficial and others where it isn't. If you've got multiple trapped nerves from the channels at the side of the spine, when the spine kinks over, those channels narrow and the nerves are trapped, you failed injections, you failed physiotherapy, then yes, straightening out that segment can untrap the nerves and help alleviate the pain in the legs. And with your posture improvement, that can help with the back pain. Again, that involves a very thorough assessment of each individual patient, a very open discussion with the patient as well as other healthcare professionals looking after that patient, the physiotherapist that may have seen them, pain specialists and so forth, to look at other options of treatment as well. And you've also got to look at that patient's comorbidities, other medical factors that might come into play and complicate surgery. So scoliosis is a very different ballgame altogether. What I was trying to say about back pain and surgery is that there are very few conditions. If you have instability of the spine, for example, where you can physically see a malalignment of two vertebral bodies, one sitting one in front of the other, that's called spondylolisthesis. And if that's unstable, then yes, surgery is a good option if other measures have failed. There just seems to have been a trend or this belief that surgery is there primarily to treat back pain, when that's the main point I was trying to make with the last video. It's there to treat trapped nerves when other measures have failed, that there are some scenarios or some causes of back pain where surgery can be helpful. So I hope that answers your question. Similarly, someone with the username Jelly of the Month asked, you're having surgery to your spine for leg weakness and numbness, should you not expect any improvement in your back pain? Well, it depends what the findings are of your scan and what's causing the leg weakness and numbness. If it's just simple narrowing of the spine, that can improve it. If it's a slipped disc, that can improve those specific symptoms. If it's instability, as I mentioned earlier, you've got one bone that's kind of moved forward over the other that's caused a narrowing and then realigning it, that can have some improvement. And as I mentioned at the very start of the video, if you've had a frank discussion, a face-to-face discussion with your surgeon who's done a formal assessment of you, gone through your scans and talked to you directly, their opinion is going to be far superior to what I can tell you on this video. It should be treated as a general guide. But yes, there are scenarios where the back pain will improve, but it's primarily there to protect the nerves. Someone called Vanessa has been suffering with nerve-related weakness and numbness in the legs. Been doing physiotherapy for quite a long time and don't really have back pain, and that's a really good thing. You've been doing all the right things so far by the sounds of it, in that I think the exercises you've been doing with the physiotherapist has probably helped prevent you having back pain. But you've been told this isn't really going to improve the nerve-related symptoms, and I think you may have been advised surgery. Well, again, it depends. It depends on what the cause is, what the findings are on your scan. If it is narrowing or trapped nerves causing that, and a spine surgeon has seen you and gone through your history and examination and your scans and put it all together, then obviously their advice is going to be superior to what I can tell you here on this video. With trapped nerves, and if you've had deficits, when I say deficits, I mean neurological deficits, so weakness and numbness for a period of time, what surgery can do in that case is arrest any deterioration of that, sort of stop it getting any worse. In terms of improvement, it's very difficult to predict. What I often tell patients, seen by myself, who when I've examined them, is I've given surgery will give the nerves some space or an environment where they can recover further. Whether they do or not is very difficult to predict. And again, this does come down to your surgeon's assessment of your care. So I hope that helps answer your question to some degree. And someone called J Kaleka 60 mentioned that they've had a laminectomy in the past and have now been advised to have spinal fusion. So just to clarify to people what a laminectomy is, this is the back of the spine here. Each vertebra consists of a vertebral body, this block of bone here, attached to an arch of bone at the back. So if you look at a cross section, you've got the disc bony area. than the arch of bone at the back. The lamina is this bit of the arch here. So when you've got a condition called stenosis, narrowing of the spine, and then compression of all the nerves in the midline, a common operation still done by some, but I don't tend to do this anymore. It's called a laminectomy, where you remove this arch. There has been studies showing that you can get secondary instability. So what I was talking about much earlier in the video about this fear that people put in about the benefits of endoscopy and all this kind of stuff about removing bone, it causing instability. If you remove the whole of the arch and therefore this kind of midline ligament, which is like a tension band that goes up and down, is disrupted, and you also remove a fair bit of this, the facet joints either side that help join these two bits together, then yes, over time that can cause instability. So, if you've had a laminectomy in the past and you have instability causing back pain, then yes, it sounds like fusion might be the right answer if other methods have failed. And again, I'm not going to dispute the advice that's been given to you by your surgeon because they've seen you and I haven't. What I want to point out is nowadays, or certainly when I treat stenosis, rather than remove the whole arch under the microscope, if I come back to this image here, here's the arch at the back of the spine. Using a very narrow retractor, I create a window in the bone at the back, and through that window I can undercut and shave away all the overgrown tissue beneath this arch of bone. So that's all the thickened ligament and overgrown facet joint. You can kind of undercut it and widen that window. That way I'm not disrupting that tension band that you've got at the back. I'm not removing a massive amount of bone. So I hope that answers your question. I'll put some links below to some of the videos on the channel that go deeper into it as well. I've got one called When Might Surgery Be a Better Option, which you might find helpful. It kind of goes into that in a lot more detail, covers a lot of what we discussed today again. And then I've got a series of videos on the different types of operations you can have on the spine for different conditions, as well as various different conditions of the spine, such as stenosis, herniated disc, and so forth. And I'll put the links down below. There's a link below to our website, which has got a blog page on it, and that's also got some useful written information as well as some videos. So I really hope that's clarified things a bit better and answered your questions. I want to thank you again for subscribing to the channel and interacting in that last video. That's a really helpful way of getting this information out there to patients who suffer with back pain or spine disease to find this channel and find information that can help them. So please click the like button if you did find this video helpful, and if you haven't subscribed, please do so. The goal of the Spine MDT is to find the least invasive method that gives you the longest lasting result, and we're able to do this by working with a whole team of all professions that deal with spine disease, so spine surgeons, chiropractors, osteopaths, physiotherapists, pain specialists, so that we can ensure you're seen by the right person, and we manage that in a multidisciplinary way so that we can achieve that goal. If you want any further help or information, please feel free to contact us through our website or email address, and wherever you are, we'll always find a way of even giving you a remote consultation and helping you. Thank you.